chairpersons and Professor Magdi, Professor Delgado. It's a pleasure to be here in this prestigious meeting to present the updates about the cardiogenic shock. Actually, when I went through this topic, it was a little bit disappointing for me. We don't have many updates about the cardiogenic shock. It's still one of the most common cause of mortality in the patients presented with myocardial infarction. The mortality rate is still about 40 to 50% in the patients with cardiogenic shock. But I will go rapidly through some of the guidelines and some of the updates about the management of the cardiogenic shock in 2019. At first, I will go through the introduction. The cardiogenic shock is a common cause of mortality, and management remain challenging despite advances in therapeutic options. Ventricular failure subsequent to acute myocardial infarction remains the most frequent cause of cardiogenic shock, accounting for more than 80% of the cases. The other 20% is due to either mechanical complication of infarction like ventricular septal rupture or free wall rupture or acute mitral regurg, and other causes like complication or acute exacerbation of chronic heart failure, myocarditis, and various arrhythmias account for the rest 20% of the cardiogenic shock causes. Despite a more widespread implementation of early revascularization with subsequent mortality reduction to 40 to 50%, it's still a leading cause of death in acute myocardial infarction. It was previously 70 to 80% mortality in the patient with cardiogenic shock before implementation of the early revascularization in these patients. And the pathophysiology goes as following. It's the acute cardiac injury, whether it's ischemic or mechanical complication or arrhythmias. This will lead to decrease in the cardiac output, leading to peripheral vasoconstriction as a compensatory mechanism, which will stimulate the initiation of systemic inflammatory response syndrome, leading to more pulmonary venous congestion, systemic and cardiac ischemia, and more tissue anoxia, with decreasing more and more in the cardiac output in a vicious circuit, leading to death at the end. So in order to stop this circuit, we have to intervene as early as possible to reverse the cause of cardiac output, as I will show later on. So by definition, it's defined as a state of critical end organ hypoperfusion and hypoxia due to primary cardiac disorder, and in the guidelines is defined as persistent systolic blood pressure less than 90 millimeter mercury, not responsive to fluid administration alone, after a fluid challenge of course, with associated signs of hypoperfusion such as creatinine clearance of less than 2.2 liter per minute per meter square, and pulmonary capillary wedge pressure of more than 15 millimeter mercury, and it's of course secondary to cardiac dysfunction. And although we have this clinical definition, yet the entry point of different trials for the cardiogenic shock were different. So we have the SHOCK, TRIUMPH, intra-aortic balloon shock 2 trial, culprit shock, and finally the guidelines, of course, the European guidelines of heart failure and cardiogenic shock. We have different entry points, and some of these trials used the level of lactate as a marker to entry into the study, and others used the ejection fraction, and others used different cutoff values of the lactate level. But at the end of the day, all of them agreed that it's a state of persistent hypoperfusion, which can be clinically assessed as cold extremities, oliguria, mental confusion, dizziness, and narrow pulse pressure, with of course metabolic acidosis, elevated lactate, and elevated creatinine level. And then this is one of the most important updates, which was powered by the SCAI, which is stages of cardiogenic shock. It divided the stage of cardiogenic shock as A, B, C, D, and E. The A is at risk. These are patients with at risk to develop cardiogenic shock, but still they are not in cardiogenic shock. They have a good blood pressure, good perfusion, but for example, they have an extensive myocardial infarction, so they are classified as class A or at risk of developing cardiogenic shock. And then we have B, which is the beginning of the cardiogenic shock. The patients presented with relative hypotension, but still has a good perfusion of the organs, and with or maybe just a tachycardia without hypotension. And then we have a stage C, which is the classic shock with the persistent hypotension, oliguria, and tissue anoxia. And then we have a deteriorating phase, which is the D, which is a progression of the phase C. And then we have the extremities, which is the patient not responding to any of the above or any of the used measures to improve the cardiogenic shock, and even he's arrested and we are doing CPR. So the stage 1 is the patient at risk. We can find clinically that he has normal GVP with clear lungs and with warm extremities and strong distal pulsations. And biochemical markers are normal with normal hemodynamics, but the patient is still at risk because, for example, he has an extensive myocardial infarction. Stage B is the beginning, when the patient has clinical evidence of relative hypotension or tachycardia without hypoperfusion. Still, we have a good creatinine clearance, we have a good warm extremities, and still the blood pressure is relatively normal, a little bit low. And then we have the classic form of shock with hypoperfusion that requires intervention such as inotropes, vasopressor, or mechanical circulatory support to restore reperfusion. These patients typically have relative hypotension, of course, with blood pressure defined as below 90, systolic 90 millimeter mercury for at least half an hour and persistent. And then we have a deteriorating form, the D, the patients similar to the C but are getting worse. The patients have failure to respond to the initial intervention we did. And then we have the extremities, the patient in cardiac arrest with ongoing CPR or advanced life support, alternatively being supported by multiple interventions. So what's the important, and then we have also the risk modification if the patient is arrested. So if the patient, for example, in class 1, which is at risk of having a cardiogenic shock, but he arrested with a ventricular fibrillation or some brief arrest, then he will be modified to SCAI shock B after being an A between brackets. And then if the patient is in a classic form of shock like C, and then he had cardiac arrest and the cardiac arrest prolonged and then hypoperfusion afterwards, then he will be upgraded to SCAI shock C after being an A. And if the initial efforts to restore the blood pressure failed, then he will be a SCAI shock D between brackets A, of course. The importance or the benefits of this classification is to identify the pre-shock state in order to reduce mortality by preventing progression to overt cardiogenic shock through initiation of adequate management strategies. And also it can make different trials of cardiogenic shock better comparable to each other and may also trigger new randomized trial on the pre-shock state. So this is one of the updates in the cardiogenic shock in 2019, applying a new definition from the SCAI and new classification. Regarding the management of the cardiogenic shock, of course, we have three main items, the revascularization, the intensive care unit treatment, and mechanical circulatory support. Of course, the SCAI also, and also the American Heart Association endorse a multidisciplinary approach in order to achieve treatment of the cardiogenic shock, including interventional cardiology, heart failure cardiologist or heart failure team, critical care cardiology, emergency medicine, critical care nursing, and cardiac surgery if needed. Still, the revascularization is the most important treatment strategy in the cardiogenic shock after myocardial infarction based on the shock trial. Although the shock trial didn't meet the primary endpoint of improved 30 days mortality, but the follow-up of this shock trial at 6 months and 1 year and even 6 years shows improved mortality in the patients treated with early revascularization in the cardiogenic shock compared to the patient who took the stabilization first or the clinical stabilization first approach. Registry shows reduction in mortality from 70 to 80% to 40 to 50%, confirming the long-term data from the shock trial. Transferal to the primary PCI center, of course, is mandatory. And is there any role for fibrinolysis in this patient 2019? Yet, if the transferal will take much longer than 2 or 3 hours in these patients, fibrinolysis can be tried. Still, we have no data or a clinical trial that showed that fibrinolysis has a benefit in the patients with cardiogenic shock, of course. Second, if the patients with multivessel, approximately 70 to 80% of patients with cardiogenic shock present with multivessel disease. Of course, they have a worse outcome than the patients with the single vessel disease. So we have the dilemma of culprit versus multivessel revascularization. Until the culprit shock trial, we had the guidelines that showed that multivessel revascularization in the patients with cardiogenic shock is of course indicated. Then we had the culprit shock trial that changed the guidelines. It showed a significant clinical benefit of culprit lesion only strategy with a reduction in the primary endpoints of 30-day mortality or renal replacement therapy. Thus, in the clinical practice, revascularization should be limited to the culprit lesion with possible stage revascularization of other lesions at later time. And of course, there is some role of CABG but it is very limited. So as we can see from the culprit shock trial, we had only something like 5% of the patients with cardiogenic shock undergone cuppage. In contrast to that done in the intra-aortic balloon shock trial, it was something like 30%. So I guess in our country, emergency cuppage in cardiogenic shock patients is very limited. So we have to do it ourselves. So this is the summary of the trials for the revascularization multivessel. Of course, the shock trial showed benefit from the early revascularization comparison to the stabilization of the patient at first, and the culprit shock trial shows that culprit-only vessel has a better outcome compared to the multivessel intervention in the patient with cardiogenic shock. And then we have the question about the axis, whether it's radial or femoral axis. Based on multiple randomized trials, current guidelines recommend radial axis as default strategy in non-shock STEMI or non-STEMI acute coronary syndromes. Yet in the cardiogenic shock, the benefit of radial axis is less evidence-based, and still we have the femoral axis as an alternative, especially if the operator is not very experienced with the radial approach, and if we need a larger French, like 7 or 8 French guiding catheter to perform the intervention in these patients. And then we have the antiplatelets and antithrombotic that should be given to the patient prior to the intervention. There is no specific trial in the cardiogenic shock for antiplatelet or anticoagulants. However, the enteral absorption is impaired in the cardiogenic shock, and oftentimes opioids are co-administrated with further impact on the enteral bioavailability. And of course, in the mechanically ventilated patients, oral antiplatelets require to be crushed and administered through a nasogastric tube. So there is a role of IV antiplatelets like the Cangrelol, which has an ongoing trial, the DAP-CHOC AMI, acute AMI trial. And of course, there is a role of glycoprotein 2B3 inhibitors. The upstream, there is no data to support the upstream use of glycoprotein 2B3 inhibitors, but we have a liberal use to use it as a downstream therapy or a bailout therapy if the patient has a heavy thrombus burden after intervention. Second, we go through the intensive care unit treatment. Of course, the basic ICU treatment includes initial hemodynamic stabilization by a volume expansion or a fluid challenge at first, vasopressor and inotropes plus additional therapy for prevention or treatment of multi-organ system dysfunction. Norepinephrine is the vasoconstrictor of choice when the blood pressure is low and tissue perfusion pressure is insufficient. Inotropes can be added to norepinephrine like the dobutamine, may be given simultaneously to norepinephrine in an attempt to improve cardiac contractility. Other inotropes such as levozimendan or phosphodiesterase inhibitors are of interest based on their myocardial contractility improvement without more hypotension, without potential vasodilatation, without increasing oxygen recurrence, but there is no data to show that they are more beneficial than the other inotropes. And here are the trials of the intensive care unit treatment. The vasopressor, of course, as we can see, the use of norepinephrine is preferred than the other vasopressors, the dopamine or epinephrine. And of course, we can see also that there is no evidence that the levozimendan can give additional benefit over the other positive inotropic drugs. In the general ICU measurements, the ventilation is required if there is persistent hypoxia or we need to do a positive pressure ventilation for this patient. Renal replacement therapy should be initiated in case of acute renal failure with clinical signs of uremia, like untreatable volume overload, metabolic acidosis with pH less than 7.2, and or refractory hyperkalemia, more than 6 millimole per liter. Based on these criteria, renal replacement therapy was necessary in about 14% of patients in the culprit shock trial. Earlier initiation of renal replacement therapy had no effect on outcome in the ICU patients with acute kidney injury. We should have a tight glycemic control, but with avoidance of hypoglycemia in these patients. The nutrition, there is no preference of the IV versus the enteral nutrition. They were comparable with no benefits of the IV nutrition in comparable to the enteral nutrition. Regarding the monitoring of these patients, the pulmonary artery catheterization, the current guidelines and scientific statement consider using pulmonary artery catheterization as early as possible in the treatment course if the patient is not responsive to the initial therapy. In case of, for the diagnostic or prognostic value, of course, the pulmonary artery pulsatile index less than 1 may best indicate additional requirements for the RV support. And regarding the bleeding, which is found in about 20% of the patients, it might necessitate blood transfusion or peripherally packed RBC transfusion to avoid the volume load. The hypothermia showed no benefit in non-resuscitated cardiogenic shock patients, of course. And then we go to the mechanical circulatory support device, which shows an improvement in the last years. Of course, there are some dedicated for the right ventricular support only, like the Impella RP, the tandem heart RA pulmonary artery, and VA ECMO. And then we have a left ventricular support system like the intra-aortic balloon pump, the Impella, the tandem heart, and IVAC 2 liters. So we'll go first in the intra-aortic balloon pump because it was the first introduced in 1967. And it was extensively used until the intra-aortic balloon shock 2 trial, which showed a very negative results. And nowadays, the intra-aortic balloon only may be considered in the patients with mechanical complications. And then we have the percutaneous ventricular assist device like the Impella. The Impella was very promising in treatment of the patients with SHIP, but without cardiogenic shock. As we see in the IMPRESS in severe shock trial, the Impella versus intra-aortic balloon pump showed disappointing results. And then we have a new development of the Impella that supports the right ventricle and can be used if we need an additional support for the right ventricle in these patients. The extracorporeal life support system like the ECMO, the VA ECMO, it has an ongoing trial in the patient with cardiogenic shock. And have we ECMO CPR. The ECMO CPR showed superiority on the non-ECMO CPR in the patients who are already arrested. And this is a summary of the trials regarding the mechanical circulatory support system, the intra-aortic balloon pump shock 1 and 2, which was disappointing. And also we have mechanical circulatory support with the Impella, like the ISAR shock and IMPRESS in severe shock trials, which was also disappointing with no advantage over the intra-aortic balloon pump. And there was a recent paper published in the American Heart Association last week. It shows that the Impella even shows worse outcome because of the complication, the bleeding complication, mechanical complication, and it is not very cost effective in these patients. And here are some general consideration regarding the use of the mechanical circulatory support devices. As we can see, if we divide the patients with cardiogenic shock into two main cohorts, we have the cohort 1, which is the patients who will survive without mechanical circulatory support. And if we use this mechanical circulatory support in these patients, they will survive anyway, so it is not very beneficial. It will add only expenses with some complication that may lead to death. And on the other hand, we have the other 40 to 50% that will not survive the cardiogenic shock. Of these patients, about 25% to 35% will die anyway because of the presence of other comorbid conditions like severe sepsis. And here we can use a mechanical circulatory support system only as a bridge for a decision or for the cure of these patients. Then we will be left with about 15% of the patients who will really can benefit from the mechanical circulatory support device, provided that we have a proper scoring system to assess who may benefit from the mechanical circulatory support devices, adequate timing of initiation, because most of the trial shows that if the Impella is initiated prior to the PCI, it's very necessary to unload the left ventricle and get a good results. Learning curve of insertion and requirements to transfer to tertiary center, the cost of the mechanical circulatory support system. Of course, the appropriate patient selection is also influenced by the balance between the efficacy, institutional experience, and device-related complication. The current guidelines recommend considering the use of percutaneous mechanical circulatory support in selected patients depending on the patient age, comorbidities, and neurological function, in particular in refractory cardiogenic shock, without any preference for device selection, which is class 2A level of C recommendation. And here is my final slide, which is the summary of the guidelines, European guidelines for the cardiogenic shock. I'm sorry because it's very crowded. So the patients should have an emergency angiography. This is class 1. And then immediate echocardiography. This is a class 1C, of course. And then if the left ventricular ejection fraction approximately dysfunction is around 60%, we should go an emergency revascularization either by PCI or CABG for the culprit lesion, PCI for the culprit lesion, of course. And non-routine PCI of non-infarction related artery is not recommended. And then we'll go, if the patient is still in shock, we'll do a fluid challenge at first, and then invasive blood pressure monitoring, pulmonary artery catheter, it's a class 2B, Ventilatory support according to the blood gases, whether we need a positive pressure ventilation or not. Intravenous inotropes, preferably norepinephrine. Vasopressor, I mean preferably norepinephrine, of course, preferred on dopamine and epinephrine. Ultrafiltration in refractory kidney disease. And then if no response, we can go, no intra-aortic balloon pump is indicated. And then intra-aortic balloon pump is indicated only in the patients with mechanical complication. And then we could use, as we can see from the other side, the mechanical complication arm, we can go, of course, for the surgical treatment, and we can use intra-aortic balloon pump once indicated in the patient with mechanical complication. Thank you.